Welcome, everyone. It's a pleasure to have you here joining this important conversation this morning. So this event about accelerating diabetes prevention in the COVID-19 era, it is obviously a so important topic, a challenge we are facing on how to prevent diabetes while several other obstacles appear with the pandemic. So thank you for your participation. And I would like also to thank Merck for its support and to this activity and also other advocacy activity at IDF. And I'll start by inviting Professor Andrew Bolton, our IDF president, for the opening of this event. Thank you.
Thank you very much, Mark, and good morning, good afternoon to all that are listening, perhaps good evening as well. So I'm going to talk briefly about the challenges to diabetes within this global COVID-19 pandemic that sadly we're all experiencing. And the next slide, please. I'm sure most of you have seen this map, which comes, of course, from the last edition of the IDF Atlas, talking about the global burden of diabetes. And we see these horrendous figures and the projected increases over the next 20 to 30 years, which are equally worrying, particularly for continents such as Africa, South America, and Asia, which are predicted to have some of the highest increase in people with diabetes living there. And the next slide, please. So we really need to be cognizant of these figures. 500 million people, and that's surely an underestimate, are living with diabetes across our world. In my country, in the UK, approximately 5 million. Recently reported from our former Vice President ADOLESCENTS in Pakistan, 26% of adults in Pakistan are living with diabetes, and it's more than 20% in many other countries, particularly in the Middle East. The projection made 2 years ago for 2045 was more than 700 million. But again, this will be a gross underestimate. And at the end, I'll tell you about the launch of this year's Atlas and when it will actually occur. And the next, please. We're also seeing a global burden, not only of diabetes, but if you like, pre-diabetes or impaired glucose tolerance, as we call it medically. And you see the figures here. They're not far short of people with diabetes. So if you add those two together, we're talking about 1 billion people at risk of diabetes or having diabetes. This is surely a global pandemic. Next, please. And we need to take action, and this is about a call to action. On top of this, when Mark, as one of our excellent vice presidents, and I took over the helm, if you like, of IDF along with our friends and colleagues, we didn't know that a couple of months later, thrust upon us would be this horrific epidemic that we're seeing of COVID-19 across the world. If we look from my country, people with diabetes don't do as well as those without diabetes. And 1/3 of deaths in hospital in our country are in people with diabetes. And some predictors of these are other comorbidities or complications, obesity, and poorer blood sugar or glycemic control. We need a parity of focus on all people with diabetes, and I keep saying this wherever I speak, that diabetes needs the attention that it deserves. And the next, please. So there are many lessons to learn, but there are also things that might be positive that we can take away from all this. But the bad things, of course, is that the pandemic of this infectious disease has led to a neglect of many conditions. And we read all the time about cancer and heart disease, but diabetes needs to be there too. The British Medical Association in my country has emphasized the need to tackle the backlog of non-COVID treatments. People are not coming to hospital. They're frightened of hospitals, quite understandably. Hospitals are where people with COVID go. But there have been positive improvements that must be maintained, including Reduce bureaucracy, we need to move faster. Video consultations, telemedicine, and so on. And the next, please. So there are pluses and minuses, but sadly many minuses. And if the next slide shows the threats and the opportunities. Of course, the threats. Many of our people living with diabetes have had to shield, to live alone, not going out, not meeting with friends. This leads to difficulties with diet and exercise. And the psychological impact cannot be overemphasized. The anxiety, this itself will also worsen or make it more difficult to get good blood sugar control. And understandably, the fear of coming to a hospital clinic. People are frightened. In my hospital clinic, the do not attend rate has reached up to 30–40%. So I moved my complications with people with diabetes complications to a community clinic where we get almost 100% attendance. So my fear is we're going to see a tsunami of the late complications of diabetes following this because of the lack of consultations, the lack of people being able to see their physician, and also the anxiety leading to poor control and so on. But as I've already mentioned, the expansion of telemedicine, I think, is a benefit. Digital education programs are available. And there have been driven improvements in inpatient diabetes services because many people who are seriously ill in hospital are given dexamethasone and other drugs which themselves bring on diabetes, making the problem worse. And the next slide, as well as I said, enforced diabetes services redesign, I've mentioned that already. But a few years ago, I shared the stage with Sri Narendra Modi, the Prime Minister of India, at a large meeting in Bangalore. And he got up and he said, the biggest threat to the health of the people of India is no longer infectious diseases like tuberculosis, like malaria. It's diabetes. And of course, I told him when we chatted afterwards, of course, you're right. But now my concern is there's going to be a swing back to infectious diseases necessarily now. But this is going to leave a legacy that might hurt non-infectious diseases, non-communicable diseases like diabetes, heart disease. And the next slide suggests some of these problems when we get there. A double whammy, if you like. Clinical research is swinging back to the infectious diseases. And this is leading, and we're doing a study, we've already shown some reduced income for some of the major diabetes associations that are charities funding research. But also clinical care is suffering throughout the pandemic due to cancelled appointments and so on, and fear of hospitals is leading to a poor attendance. So there are threats, and we must be cognizant of that and really help our people with diabetes, especially as hopefully we soon are coming out of this pandemic. And the next. So I think it's important that we have collaboration between stakeholders, all with a major interest in non-communicable diseases. IDF, we'll come back to that. WHO, Non-Communicable Diseases Association, Global Coalition for Circularity Health, and our many friends and partners in the pharmaceutical industries. We all need to be working together in the interest of preventing diabetes, which is eminently preventable in many cases, but also in helping those with diabetes with good control and hopefully reducing the threat of the late complications. We need to increase global awareness of diabetes as a serious life-threatening condition. And this is a very important message to politicians regarding what's happened to people with diabetes, but also the increased incidence of diabetes during this pandemic and the costs that this is leading to. And the next. So we're very happy that we were founding, with the WHO, we were founding members of this WHO Global Diabetes Compact that we spoke at under launch just 2 weeks ago. It's focusing on treatment and prevention. Prevention is such an important priority. Many studies have shown we can intervene in impaired glucose tolerance or prediabetes and prevent progression, addressing obesity, for example, amongst young people. And I think the next slide, well, that might be my last slide, I can't quite remember. It is, so I'll now hand back to Mark, and I'll come back to you at the end with a few final comments and closure. Thank you very much.
Thank you very much, Professor Bolton. Your introduction words were very insightful, I think, and it opened our event, giving us a taste of what is coming, since we will have an specialist on IGT, so pre-diabetes, so we will hear from him very soon. Also, a specialist from Pakistan talking, so Pakistan, where the prevalence of diabetes is nowadays above what we could imagine a couple of years ago. And about what you mentioned, Professor, also that caught my attention, the tsunami of complications that may be coming after this this pandemic, where people, where we hear, at least we also learn from Dr. Francesco Branca the numbers, but also we hear very often that people are having a less healthy lifestyle during the pandemic, which can lead to obviously more NCDs. So a tsunami not only of complications in the ones living with diabetes or living with hypertension, but also a tsunami of new cases of diabetes, hypertension, obesity, if this is not carefully managed. And one thing that I would also like to call the attention of everyone, that we are saying here, prevention in the COVID-19 era, but what I recently learned is reducing the risk would be the best term. So sometimes to be used in substitute prevention for reducing the risk. And I think this is what we want. We want people with diabetes to have access to their treatment, quality of care, and this way to prevent complications and also to prevent severe cases and mortality. There are higher when people are off target, as we learn from different researches. Well, now I'm gonna introduce our panelists. Dr. Francesco Branca, who's the director of the Department of Nutrition and Food Safety at WHO, will be our next speaker. Thank you, Dr. Branca.
Thank you very much, Mark and Andrew, for the opportunity. So I'm going to answer your three questions. And first of all, COVID-19 and prevention. If I can have the first slide. Unfortunately, diabetes is, as well as many other non-communicable diseases, a factor that is making the COVID-19 worse. And so you're seeing that, in many of the countries that have looked at this, really a high proportion of the people with COVID and with complication for COVID as non-communicable diseases. Next slide. We now have an assessment of the risk of one of the important risk factors for diabetes, which is obesity, on severe COVID-19 diseases. This is the outcome of a recent systematic review, and clearly you see, people with obesity get more to the hospital, get more on respirators, and they actually die more than everybody else. So clearly, prevention of obesity and diabetes is also important for the prevention of severe complications of COVID-19. Next slide. COVID-19 has made things worse, unfortunately, on these risk factors. And I mean, we sort of saw it coming. We thought that, sedentarity, changes in food habits would have an impact on obesity. We now actually have the documentation, and these are DAR data from studies in children. You see in this large number of children, we can see that actually children, adolescents, young adults, they all gained weight. There were changes in dietary behaviors and not certainly towards a healthy diet. Next slide, please. And then, of course, the non-communicable disease services have been disrupted. And we did a first survey last year, immediately after the at the beginning of the survey, and that was showing that at least half of the services were disrupted. And this is the latest pulse survey that we've conducted in about more than a half of the countries, and you see that still non-communicable disease services are broadly disrupted in over a third of those countries. In some cases, they've been completely disrupted. And unfortunately, diabetes services, prevention and management have not made better than the other one. So cancer, hypertension, diabetes, but probably diabetes has even been hit worse than the other one. So that's the situation. COVID have made things worse in many ways on prevention and management. Next slide, please. My second question was, what are we doing with diabetes plans? And this is again a recent analysis that WHO has done on the diabetes plan. You see longitudinally, and if you look at the last set of columns where you see the global picture has been improving in years. I think we've seen a little bit of a flattening of the situation in the last few years. But about 80% of the countries have diabetes plans. And some of the regions, you can see the African region, for example, perhaps a little bit less, but in fact the South Asian region is doing better. So India and Pakistan, they do have the plans, but then what is going wrong? Why are we not seeing any better epidemiology? Next slide, please. Probably one of the reasons is the quality of the plan and the implementation of the policies. This is a quick analysis we have done on the healthy nutrition part. I mean, you have a nice proposal for plans. So one of the components of prevention is called Make Healthy Nutrition Available for All. And what's the situation there? I mean, this is a global analysis based on data, a couple of years old. Population campaigns, everybody's doing that. But then when it comes to school food standards, changing the food environment, having, healthy food in Social Security, or even the taxation, which is bringing down the consumption of sugar-sweetened beverages, for example, very few countries are doing that. I think we've increased recently, but taxes for healthy diets, only 20 countries, taxes for sugar-sweetened beverages, 74 countries. But still, you see, we can do much more. Front of the pack labeling, very few countries. Nutrient declaration on the labels of processed food, about a third of the country. So that's why the prevention is not effective, because some of the effective policies are not broadly implemented. Next one. And then your other point about physical activity, promote everyday physical activity. We hope that will contribute to that. We have WHO guidelines on physical activity and sedentary behavior. We have a global action plan on physical activity. Now we need to move to the implementation of it. And, we were looking at your collaboration for that. Next one, my third question was about the data. And I do agree that this is an important element. Actually, in WHO, we rely mainly on the NCD risk factor collaboration, which is bringing together many studies, particularly looking at diabetes more than impaired glucose tolerance. Next slide, please. So this is what we have in our Global Health Observatory. We have basically raised fasting blood glucose, and on the right you have the section of our STEP service that people have to fill in. We have pretty broad representation of countries who have completed the surveys, but the question is about simply the fasting blood glucose. We're not able to get countries to do a glucose tolerance test and have better data. So just closing here, saying that this is definitely one of the actions that we will need to take and improve the data part and the surveillance part, and definitely the global diabetes compact is going to be very important collaboration among all of us to make progress on prevention and management of diabetes. Thank you very much.
Thank you very much, Dr. Branca. I think it was a nice overview of the challenges we are facing and the need for action, especially towards implementation of measures to prevent diabetes, and especially as you highlighted in terms of healthy nutrition policies in the different countries. Now I'm gonna invite for the microphone Dr. Justin Ashufu-Tuwagi, whose special interest group on IGT at Johns Hopkins. Thank you very much, Doctor.
Thank you, Mark, and thank you for giving me the opportunity to talk about the opportunity that digital health offers to sort of improve the prevention of diabetes. And I think this opportunity was sort of more or less highlighted by the COVID situation. As you all know, the COVID situation led to a sort of limitation of interaction between the patients and physicians. And overnight, we sort of switched to telemedicine, and it sort of brought to the fore the reality of or the possibility of using telemedicine to provide care. And I think this is something that could be leveraged to prevent diabetes. And on this slide, so what I sort of highlighted here, the sort of challenges that we were facing even before COVID in sort of delivering type 2 diabetes prevention. There was a limited number of providers for the patients with IGT, so a low patient to provider ratio, which was already limiting the delivery of diabetes prevention. And I think with COVID, we're sort of realizing that digital health could be very important. And there was also a poor access to care even before the COVID because of geographical limitation, because of travel limitation, because of time barrier, which sort of were also highlighted by the COVID situation. And one other challenge of diabetes prevention was that of cost. So, and also in the COVID situation, who is going to pay for diabetes prevention, especially if we can't do the in-person delivery of the intervention. So digital health offers an opportunity to scale up the prevention of diabetes and to come up with convenient and flexible programs that can be delivered efficiently to those who need those intervention. Next slide, please. So on this slide, I just wanted to sort of highlight what will be the key characteristic of a digital health program for diabetes prevention. There are numbers of digital health prevention programs that have already been tested out there. And so what I set out to do is just to highlight sort of the key features that are common to all those programs. Obviously, we know from the DPP what a potential curriculum for diabetes prevention will be. So applications, the program is adapted to be delivered through a computer. It could be through email, to the web, or through a mobile phone. There's also a live coaching component, which could be done using different platforms. So I put the WebEx and the Doximity Dialog platform because those are the ones that we've been using in clinical practice since the beginning of COVID to provide telehealth. Another component of a digital program will be the tracking component, which could be done using smartphone apps or activity trackers, or even digital scales, whereby people have a scale that is connected to a platform where they could record their weight, and that helps to track the progress of people. And then also a component of peer support, which could be done through several different platforms, social network platforms, and which could be accessible by peers who are taking part into the prevention program, or by family and friends. And that would create a sort of emulation for people to try and reach their goals. And also on this slide, I included a number of programs that are already in existence. These were in existence before the COVID era, and I think with the COVID, that offers us the opportunity to implement those programs. The programs that I put here are programs that are recognized by the Center for Disease Control. They've been more or less tested. And I think one of the key reasons why the CDC recognized it is because these are programs that could be recommended to employers who are going to be funding the diabetes prevention. They're going to be, covering their employees. And we have 3 programs: the DPS, the Noon Health program, and the OMADA Health program, which you can find online. Next slide, please. So having listed some of those programs, so I just wanted to give you a flavor of what could be achieved with one of the programs, and I selected here the OMADA Health program, which was tested in a clinical trial, and the intervention was obviously delivered digitally with all the components that I mentioned previously. There was live coaching, there was also a peer support that was implemented, and there was also a component with activity tracking. And as you can see, the results are sort of encouraging. Over a period of 12 months, there was a significant reduction in the A1C of the patient, and a significant number of participants in the intervention group had the A1C that went back to normal. There was also an important weight loss, approximately 5.4% in the intervention group, which is what we sort of aim for. We aim for a 5 to 10% weight loss when we deliver an intervention, which was more than what was observed in the control group. And a significant proportion of the individuals who underwent the OMADA Health intervention in this study achieved a 5% weight loss or greater. It was 44%, which was greater than the 21% in the control group. So one of the key questions when establishes that a digital health prevention program for diabetes is actually efficacious or effective in terms of reducing the health outcome, one of the key questions is that cost effective, or what is the cost? Next slide, please. And this is just an example of a real world a DPP type digital health intervention that was evaluated to see how much it's going to cost. This was done over a period of almost 2 years, 1 year before the intervention and 1 year after the intervention. And somebody looked at the claim data to see how much could be saved by implementing such an intervention. And then at 1 year after the intervention, there was an overall reduction of healthcare expenditure, with a reduction that was a little bit more than $1,000 per participant compared to those who did not actually undergo the intervention. And a significant amount of that, the amount saved, which was $699 per participant, came from a reduction in the inpatient spending. So people were not sort of admitted into the hospital as a result of that diabetes prevention program. And then there were few hospital admission, and then and the length of stay in the hospital was shorter. And then there was also a persistence of the cost save over the course of the second year of the intervention. So this was just to give an idea of the fact that a digital health intervention for prevention of diabetes could be cost saving. So, and I'm going to stop here and thank you.
Dr. Ashofu Twegi, I would like to thank you very much for sharing those results. I think it's very encouraging to see that telehealth, digital health is working, is cost saving, and with concrete outcomes. I think this is important to have in mind. Clearly, the crisis, the pandemic made us speed up the development and the implementation of digital health and telehealth. And obviously, we need to feel that we need to have results that show us that it's concretely working well. Okay, thank you very much. And now I'm gonna call Ms. Jacqueline Bowman. Ms. Jacqueline Bowman is in the US policy. She is the lead in the European Association for the Study of Obesity and head of expert secretariat to Obesity Policy Engagements Network, OpenU. And I should also say that she is now in Europe, but actually she is originally from Guyana. Thank you very much, Ms. Baumann.
Thank you so much. I think the Guyanese diaspora is much larger than it is actually in the country. But anyway, thank you. First slide, please. Good afternoon, everyone, and I'm so delighted to be here and actually pick up on some points which were raised both by Dr. Branca as well as the previous speakers. I'm going to spend my 5 minutes telling you a little story because within the obesity world, click please. Within the obesity world, we have been struggling, I would say, for about 20 years, where the science has absolutely evolved. And within ARZO, we represent 36 different countries within WHO and beyond region across Europe for all professionals, from basic research scientists through to clinicians, through to all of the health professionals related to obesity, as well as the patient voice. And what we've seen is that on paper, so the science and the WHO definition for about 50 years has been that obesity is defined as abnormal and or excessive accumulation of body fat, which represents a risk to health. Nothing about weight. I'm going to come on to that. Now, how that's been expressed over time is that there's been this oversimplification, which has boiled down to eat less, move more, energy in, energy out. And unfortunately, which I know speakers coming up next will talk about, a complete stigmatization of the disease of obesity. So it's been represented as a lifestyle choice, not a real disease. I'm sure that you've heard all of this as well related to pre-diabetes and type 2 diabetes. Click, please. So what happened? Well, to put it bluntly, COVID-19 happened because all of a sudden, amongst looks of absolute confusion with policymakers at EU level, national and territorial, so regions within countries level, they all of a sudden couldn't comprehend that weight could be killing people, as Dr. Branca said. All of a sudden, they had to start talking about chronic inflammation, about immunocompromise in relation to obesity, and most importantly, they had to recognize that, and they did on paper in June of last year, they had to recognize that people with severe obesity actually were about 113% more likely to have a negative prognosis once they got to hospital with COVID-19. So and two other major occurrences happened as well at the same time, and I know happening globally. Firstly, that all policymakers suddenly realized, well, we can't come out of COVID business as usual for any of our policies, never mind health. And at the same time, there's been a whole momentum growing, certainly at EU level, to say that science needs to inform policy. So let's actually make some policies to that effect. Click, please. So how is it going? Well, and I'll explain how we got there in 1 second, but in under 18 months of really pushing, the obesity community has managed to have obesity updated in a commission briefing to policymakers, published, I've given you the link, describing in the language of chronic disease, pre-obesity and obesity, our medical conditions, that was down to COVID, then the WHO definition, and then the European Commission, which is the instigator of about 95% of legislation which gets transposed into national policies, not healthcare, but that's another story. Obesity is a chronic relapsing disease, which in turn acts as a gateway to a range of other non-communicable diseases, such as diabetes, cardiovascular diseases, and cancer. 18 months compared to 10, 15 years. Next slide, please. How did we do that? Well, actually, click. I think the main element of this has been to have one clear and precise narrative. We at EASO worked on basically nurturing relationships based on the science that has always been there, but we actually gave it a chapeau. We gave it a framework that could relate back to policymakers. We also decided to really, how can I say, embrace this whole idea of evidence-led policy. And we also took into account, given our researcher background as well from a lot of our community, that actually what research questions are addressed come through to policies, and there is something called implementation research as well. So if you actually are able to embed the right questions which deal with the disease of obesity, not the different symptoms, then you're actually able to have a basic foundation, both of evidence, of research coming through the philanthropic pipeline, as well as you recognize top-tier data that can then be used to address the right questions at the right time, at the right stage, and not just keep on business as usual, saying, well, it doesn't matter what stage you are of the disease, we'll just do a bit of prevention. And I'll move on very quickly. Then we have, click please, the language across. We've been working on joint research projects, part of which is about the language of obesity. Next click, please. And then what happens is the discussion, which is not just one stakeholder, it is your allies that you've educated. For us within the European Parliament, we're very proud to be secretariat to an interest group for Euro parliamentarians, and then open EU, multi-stakeholder, including IDF Europe. So the conversation becomes implementation rather than if. Last slide, please. And so what we have left is, what do we say? I think the key lesson that we've learned, before I hand back to Mark, the key lesson that we've learned is education, education, education. It's great to have something on paper. If nobody understands what it is, what's the point? Look, start with your desired outcome. Scientific details can follow. The science is there, but not in silos. Ask yourself, instead of talking directly diabetes, 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 you will have pushback and you will have misunderstanding. What triggered the biology of 80% of that type 2 diabetes? What are the biological markers? So I leave you with that point, because I can see that we need to move on. I leave you with that point, but I think it's really important in the first instance to understand that most policymakers at any level who need to design and implement these policies, they're not scientists, they're not doctors, they need precision and they need a clear story and a narrative that goes to health outcomes.
Thank you very much, Ms. Bone. I think we are with you. We need to get together and to educate policymakers, decision makers, to make sure that the policies are implemented. And something that I wrote here while you were talking is that if we do not reduce risks and treat obesity, we won't prevent many new cases of type 2 diabetes. So it is important to have this commitment in preventing. I would say, reduce the risks and also treating obesity in order to be able to prevent many of the new cases of diabetes. Before calling our next speaker, I would like to remind you all to write your questions at the chat. Then we will try to answer them all at the end. And now I'm gonna call Mr. Travis Friends, so our specialist who is leading with type 2 diabetes. So he is an IDF young leader and who's committed with advocating through social medias, especially. He's talking from South Africa. Thank you, Ms. Friends. Mr. Friends.
Hi, thank you so much, Mark. It is really an honor to be on this platform to share my story. And this is one of the many reasons why I joined the IDF, is to share my story. And it was because of someone else's story that changed my life. And that's why I've entitled this presentation Metamorphosis, because you will see the drastic change that took place in my life physically. But what you need to understand is that the physical was just the result of it, but it all had to start somewhere else, and I'll show you where. Can we please go to the next slide? Awesome. Fighting against stigma. This is one of the biggest barriers that one can ever face, especially when you try and make a whole change, is that you need to fight against stigmas. Why do we need to fight against it? Well, stigmas do play a huge role in the way we see and do things, situations, or people, right? And then stigma is also a lack of information that has been passed around or disguised as a truth, you know. And after equipping yourself with the proper information, best believe that that is the face that I will make or even think about when I hear certain stigmas. The most common stigmas that were said or for me was that I was lazy, right? That I was fat physically, of course I was fat. And then it's all the sugar and the sweets that you eat. Bear in mind, my mom's a baker and I learned to bake as well. So you have that. And then it's all your fault. And funny enough, that was a stigma that I placed on myself. And I'll explain to you why. And this is one of the things that affects young people, especially in this day and age. One of the things that I've heard that is very, very profound is a line from a song from her. And it said, "We're all slaves to a generation socialized, and sickness is in the mind." And with that being said, we are a generation now that is glued to social media. So stigma is a huge thing. Stigma can block you from doing whatever you want to do. Can we please go to the next slide? So I want to show you my life journey with type 2 diabetes, the physical changes within these pictures and within the years that you will see. Can you please go to the next slide? Okay. So you will see that there are physical changes, but the physical changes happen throughout or in intervals of a year, basically, because I was diagnosed in the year of 2016, midway through my university years. Can we go to the next slide, please? Okay, my experience with diabetes, or the way I started with my diabetes basically was the phrase, can we go to the previous one? Was the phrase, "You shall live and not die." And the other phrase that also kickstarted my diabetes journey was so and so, naming a person, is off their medication because they changed their whole lifestyle, their whole diet, their whole exercise routine. And I know it is such a cliche to say that diabetes has changed my life, but I can also say that diabetes has redirected my perception, the way I see things, the way I see, the way I perceive things as well. So at first, myself. And the way I was doing this was by going on strict diets, by not even eating at all. And you would joke as university students saying, I'm going to sleep for supper, right? And so that's what I did. I slept for supper. I would push myself beyond the limits, especially with exercising, to the point of, okay, if whatever happens, happens. I don't care. And that was because I wanted to prove people wrong. And that was one of the stigmas like that was messing in my head. So that was the most difficult part for me to do and to change, was my mental. I had to change my mindset. And so I started there. I had to get the information, the proper information, because knowledge is power that we need to know. And that I had to realize and understand that, yes, they call this a chronic illness, they call this a chronic disease. So this cannot be a sprint or a 5K race, but it is a marathon. It's here for the long run, right? And the fact that with me, in my case, it was a pre-diabetes, an IGT situation, and I didn't know you could make a change the way I did. And so I realized that I had to start for myself. I couldn't think about what other people said. I couldn't think about what they said, because if I had to live by their opinions, hey, I'm going to die by their criticisms, or I'm going to just be despondent whenever they say something else. And so when I started with my mind, it went to the physical, right? And then from there, my emotions. So I became more confident. And that's when I realized that this is the holistic approach that I need to take, that it starts with my mind, and then it goes from my mind to my body, and from my body spiritually, emotionally. Can we please have the next slide? And within this, I learned a motto that I live with right now, called E4, which is equip, evolve, empower, elevate. And yes, whenever I feel down, you got to do the Superman pose, right? Okay, so I believe that E4 is the key to success in all aspects, right? You got to equip yourself with the proper information. Then after that, what happens is there is a natural evolution that takes place mentally. Your body becomes the result of the mindset that you are in. So man thinketh, so is he. Once that happens, you are empowered. And then once you are empowered, once you've built that confidence within yourself, because you know that that's what you did, right? Now it is time not to only be elevated by yourself, by what you have achieved, but also to elevate the people around you. And that's how I look and how I perceive life right now. Thank you so much.
Thank you very much, Mr. Travis Friends. It was very empowering, your speech. And we will move to our next speaker. So Dr. Aaron Gafour, it is a pleasure to have you here, my old friend. So Dr. Aaron is an IDF Blue Circle Voices member living with type 2 diabetes and a very globally well-known diabetes educator. Thank you.
Thank you, Mark, for the great introduction. And I am very thankful to IDF for inviting me, for providing me this opportunity. Next slide, please. Well, I will not go with the numbers and the data because our senior colleagues has already discussed its importance and the criticality. So I would like to just briefly showcase that the pre-diabetes is not an issue of specific countries, or because if you can see, there is prevalence is increasing in high income countries as well as in middle income and low income countries. So it is a global issue, and these figures are showing that if the number is increasing like that, then we will have more and more people with type 2 diabetes. So next slide, please. Well, living with diabetes is not easy. Here, I would like to share a brief story of my journey. And I've been diagnosed with PCOS at the age of 11. And due to hormonal disturbance, I was gaining weight. despite of doing anything, I was keep gaining weight, and it was very difficult to manage at that young age because I was not even understanding that what is going on. And then after the 3 years, I have been diagnosed with type 2 diabetes at the age of 14, which was indeed a great shock for me and for my family. Though I belong to a very educated family, but I have learned that being educated and being aware are two different things. Because at that time, nobody knew that how to manage what to do. Uh, and I've been even stigmatized many times in many ways. Even my family and my parents have been told that they shouldn't spend money on my studies because I can't study. And I've been called with many names like a burden on society or ill-omened child or barren woman or something like that. So there are many things which was there, and I've been stigmatized by them. And I must say that I will never forget that at that time when I was diagnosed, I used to hide in a storeroom, and I was just nowhere. My life became gray. Next slide, please. And I've been even discriminated and rejected for the higher studies many times just because of diabetes. Because I've been considered that person who can't take the burden of higher studies. So that even happened with me. Next slide, please. Well, uh, now you can see on screen the two supporters of me who made me uh, a star, I would say. And I'm lucky to meet an amazing endocrinologist, a life changes personality, my wonderful mentor, Professor Abdul Basit. He was the person who paved the way for me. He asked me that, Iram, you should go and you should be someone who can professionally know how to improve the lives of people with diabetes while living with all the feelings. And in that way, my family has supported me a lot. So that's how I have gone through all this journey. Next slide, please. With a professional and personal experience, I have learned that epidemic of diabetes can only be controlled by targeting the root cause, which is prediabetes. And we can prevent prediabetes by healthy weight loss from 5 to 7% and at least 150 minutes of physical activity per week and by reducing the stress. So these are the three measures. If we take them, we can even reduce the numbers of prediabetes. Next slide, please. Though it seems that these measures are very easy, but who will implement it? I think the best person who can implement these measures, that these are the people with diabetes. I would say that we are the game changers who can do that. And luckily now we have many networks like Blue Circle Voice, that young leaders in diabetes, and IDF members. So it is us because I feel like we feel it, we live with it, and we struggle with it on day-to-day basis. Next slide, please. So these are some strategies which can be taken, which can be initiated by us. And first is initiating online campaigns. For example, we can start campaigns for healthy eating, for physical activity at home, dealing with the stress. We can use our networks for addressing general public, involving families, and even we can involve the community leaders. We can use social media, just as Facebook, Twitter, and mass messaging, to break the ice and also to change the stereotype of mindsets that nobody can lose the weight and nobody can do the physical activity, or maybe sometimes people, even in Pakistan, maybe sometimes people think that physical activity is a sort of luxury or fashion. So we can also do the live sessions. For example, we can do the live sessions for avoiding junk foods. We can do live sessions for the healthy cooking. We can do some live session for the physical activity, that how we can perform the activity at home in one room. And we can use electronic media. For example, now in this COVID era, people are just watching TV and being at home. So we can even convey a simple message that in the commercial break, just go out and take some walk inside your house and the rooms. And if you are talking on your cell phone, then you can even talk while walking inside your home. So this is how we can do that. But now, last and not the least, the connection with other organizations. We can connect with other organizations like WHO, the UNICEF, and other bodies, and we can come up with some movement for the healthy lifestyle and inspire more people to come with us and adopt a healthy lifestyle for their betterment. We must remember that we people with diabetes are the game changers, and together we can be a very strong team. Our team wins not because the seniors or the star players, but due to the game changers, because they do not wait for the chance to score, they create chance to score. So that's how let's be together and fight with diabetes.
Couldn't agree more with you, Dr. Ghaffur. It is key to work together and also to count on peers. We know how powerful it is to be empowered and to be in a network with peers to support each other, right? And also now that we have many challenges, to find new ways to overcome those challenges. So our time is close to be over, but I'll invite all speakers to come back here for 1 minute. I'm not sure if you have time for the questions now, but I believe we will. But I'll ask each one of the speakers to answer in 1 sentence the questions we have for you. Let me see here some of the questions if we have them then prepare, or maybe should I suggest that we answer them online, that we share on our webpage the answers, or we have the questions available for now?
I think we could probably go over by 10 minutes if other people agree, Mark.
Okay, perfect. So if you could, I think each of you have received your questions. If you could read your question and answer in 1 sentence, that would be nice to allow the other speaker also to answer. Thank you.
Shall I go first? I seem to be first in the
Yes, please.
the list. Okay, so 10 minutes. Okay, so there were 2 questions, but the one I'm going to pick up on, because I can lump them together, is what do we, sorry, where's it gone? It is basically what steps should be taken at an international level for controlling obesity, particularly during the current pandemic. And I think we can take the example from Europe, which I see that certainly at global level is starting as well. Actually implement obesity as a chronic disease and prevent 80% of type 2 diabetes. That means, because there was a comma in there, that means actually differentiating between onset and disease progression along the life course. Do not keep on business as usual with primary prevention regardless. And that is actually how we start to move towards management and long-term control.
Thank you very much. I have here other short questions, one for Professor Bolton. Is it true that COVID can cause diabetes?
I think I would say directly the jury is still out. Indirectly, through medications that are being used, as I mentioned, dexamethasone, through the stress of an illness can bring out type 2 diabetes in people who are already predisposed, and the stress of being in hospital is immense, and all these things are contributory.
Thank you very much. One addressed to Dr. Branca. It is key that healthy habits are promoted in schools and sugary drinks are not sold. So if you could comment that.
Absolutely, it's not just promotion, it's actually the school food environment, what children are offered in schools. And there's a responsibility for the administration, the governments, to buy the food. I mean, 20–25% of public health expenditure goes on food. In Brazil only, Mark, you know, 43 million meals sold, offered to children in school. So it's an enormous power, it's an enormous opportunity. And then, of course, avoiding that the certain foods or drinks are offered in schools. I mean, sugar-sweetened beverages, high salt products, products containing trans fat. So we need those clear standards.
Thank you very much. Yeah, I think it's a huge challenge, right? Not only I think for the individuals, but also to implement policies, but also to educate the people who, you know, the kids and their parents that sometimes do not understand why school food should be healthy. And I have the last question for Dr. Gafour. So why is T2 diabetes increasing in people under 25 years old? We cannot hear you. No, I cannot hear you yet. So in case your sound is not working, if Professor Bolton could comment on that, it would be wonderful.
I think that much of it is genetic and change in lifestyle in many countries. I think we don't know the true answer, but certainly in certain ethnic groups here, I'm seeing young people with diabetes. And I think that there is an ethnic risk, and combined with change in lifestyle and so on, this is happening across the world.
Thank you very much, Professor Bolton, and I'd like to thank all our panelists for the very rich discussion we had today. And I invite Professor Bolton for the final words.
Thank you very much, and thank you very much to all the panelists. It's been a fascinating discussion to hear from friends from across the world, including my favorite country of South Africa, there I think in Eastern Cape, and from Pakistan, from the United States, from Europe, and from everywhere. It's been a delight. So thank you all so much, because prevention is the most important thing, and that's what we're focused on this afternoon. And the next slide. I just want to say how committed we are as the International Diabetes Federation to diabetes prevention, through advocacy, through education, through awareness. And we give 100% support to the WHO Global Diabetes Compact, especially with focusing on access to care and prevention. We know from studies, as Dr. Branca has mentioned, firstly from Finland and then from the United States and across the world, Japan, China, and that is that lifestyle changes can have a huge impact in preventing diabetes. And in preventing diabetes, we're helping people who have the misfortune to get COVID, but likely to do better. I would also like to say that we are planning to launch a Diabetes Prevention Week. As you know, we have a month of diabetes. Last year, we focused on the importance of the diabetes nurse, and this year, of course, on the centenary of insulin. So we're going to launch a Diabetes Prevention Week. We need to take action on diabetes and its prevention. If not now, when? It has to be now. And the next slide. So I'm really launching a global call for action to increase awareness of diabetes as a potentially preventable condition. And to those who have diabetes, we can prevent the complications. So we're talking about primary prevention, secondary prevention, and so on. We can do so much to help people with diabetes and to help people at risk, perhaps prevent the transition into diabetes. And the next call, perhaps it's best to me to end here. You might be surprised, from the Old Testament, from the book of Ecclesiasticus. And in chapter 18, verse 19, it says, "Before you speak, learn, but before you fall ill, take care of your health." And that's true for us all, whether we have diabetes or not. If we're at risk of diabetes, of course, take care not to progress. If we have diabetes, take care not to develop such complications. We can do so much, and I'd like to echo Mark's thanks to our friends and partners in Merck for their really important contribution to this afternoon. Thank you very much, and I hope you've enjoyed this session. And I thank Mark for fantastic chatting.
Thank you very much, Professor.
I've got to make an advert here, yes, with permission, Mark. We have our diabetes complications, virtual congress coming instead of our World Diabetes Congress, which was going to be in Bangkok. We will launch the Diabetes Atlas 2021 during this conference, and we will also have a symposium on the centenary of insulin and a whole stream on diabetes and COVID, which might help answer some of your questions from today. Please look at this on our website, and we have very attractive registration rates, especially for people from low-income countries. Muito obrigado, Mark. Muito obrigado.
Muito obrigado. Thank you very much, Professor Bolton. So I'd like also to thank everybody who stayed with us during this morning, afternoon, or evening. And thank again Merck for the support to this activity and other activities in IDF. And I would also add that after this wonderful event, we should have in mind that we need to continue carefully managing our diabetes or preventing, so reducing the risks of type 2 diabetes for our health, or for also supporting others. Thank you very much, and send any questions to the email you see here on the screen. So advocacy@idf.org. Thank you. Goodbye.